Welcome to Health IQ. I'm Dr. Alan Siegel, your host. Today we have a special guest, Dr. Michelle Castiello. She's with Scarsdale Medical Group. She's a board-certified podiatrist. Welcome, Dr. Castiello.
Thank you. Thank you so much for having me.
So as a podiatrist, you deal mainly with the foot and ankle, and obviously there's a lot of bones down there and a lot of tendons and a lot of things that can go wrong in the foot and ankle, and I'm sure over your career you've seen a lot of different things. What are some of the more common problems that patients see podiatrists for?
Very commonly, I would say the most common thing is foot pain in general.
Okay.
And usually people come in after they've been in pain for a while. A lot of people ignore pain. A lot of people ignore their feet. We don't pay attention to our feet till something is going wrong. So patients will come in with complaints of heel pain, ball of the foot pain, ankle pain, pains to their toes. So it's usually pain, and it's usually pain that's been going on for a little while, because unfortunately, pain in your feet should not just be a fact of life. We kind of just, say, well, I'm getting older now, my feet are supposed to hurt, or I exercise regularly, my feet are supposed to hurt. They're not supposed to hurt. But most people come in, I would say, for some type of foot pain. And the most common right now, I would say, is plantar fasciitis, which, if people are not aware of that term, very often it's also called heel spur syndrome, or just when they come in with severe heel pain. And that's kind of what I see.
Bottom of the foot,
okay. Exactly,
more
exactly.
Towards the center to the back part of the foot?
More towards the back of the heel. And what's kind of interesting about how plantar fasciitis has kind of been progressing in my practice is it used to be something we'd see more in a younger population. So high school athletes, 20-year-olds, 30-year-olds, people who are very, very active. Now we're seeing it in all age ranges. So people in their 40s, 50s, I even have patients now coming in their 70s and 80s, because people are a lot more active than they've ever been before. People aren't necessarily retiring at 65 anymore. They're working longer. And I have so many patients, believe it or not, in their 70s or 80s who, will tell me, they're getting ready now for a tennis season and they play 3 times a week, or they're getting ready to play golf, once a week. And so being more active makes you more prone to heel pain and plantar fasciitis. Right. So we've kind of seen it spread.
Our feet and ankle are, we're weight bearing, we're on our feet and a lot, obviously, and we walk, and it takes a lot of brunt of our everyday, lives.
They take a lot of abuse, yes.
Certain things that are predisposing people to plantar fasciitis, or things that can be either prevented, or is there a way to, is someone more predetermined to have something like that?
Well, absolutely. It's interesting you mentioned how, our feet, again, I always find that it's the last part of the body people pay attention to, but it is your weight-bearing part of the body. And with every step that you take, about the amount of pressure that gets put to your foot is equal to your body weight. So just imagine every single step, that amount of pressure getting pushed up in your foot. So that makes you right then and there just prone to plantar fasciitis. But there's kind of 3 common reasons why people get plantar fasciitis or heel pain. One is really just the structure of their foot. It's much more common in people who are flat-footed, or what we would call having a low arch. It's also very common for activity, like I said. So typically I see a big increase in plantar fasciitis come like the new year, after everyone's made their New Year's resolution that they're going to start exercising. So people who have been kind of, sedentary for a while, and now all of a sudden they start exercising again, or they used to, let's say, walk a mile, and now all of a sudden they said they're going to increase it and they're walking 3 miles. So a sudden increase in activity or change in activity can cause it, and shoe gear plays a huge part. A lot of things that occur in the feet are related to shoe gear, and let's face it, we're always in shoes.
Well, that's a great point. I mean, a lot of technologies when you're talking about athletics and sports, with the advancements of sneakers, just in general over 20, 30 years, some better advancements, a lot of gimmicky things, air,
Right, exactly, yes. And we saw the big craze of the rocker bottom sneakers and all of that. And
of course, so some things probably work better than others. Some companies, are better for runners and better for cross training.
Right.
But it is important to outfit your foot with something well-made.
It is, absolutely. I mean, I always tell my patients when they ask me about starting to exercise, I always say, well, the first thing you have to do is evaluate your equipment. And they look at me, they say, well, what are you talking about? And I say, your equipment is your sneakers. You have to make sure you're in a good supportive shoe, or, there's no point. You're going to end up injuring yourself. And so it's important to make sure the shoes fit you properly. A lot of times when we're buying shoes, and especially these days, sneakers are expensive, and so people will try to buy a shoe that's a little bit bigger because they feel like maybe they'll grow into it if it's a younger person, or they'll buy a shoe that doesn't quite fit right because they say, well, it's close enough, and then they end up causing injury because the foot just doesn't, the shoe just doesn't fit them correctly.
And then we always have the high heel pumps that women tend to wear, and those can cause different types of problems.
Absolutely. So a lot with, high heels, we see a lot of ball of the foot pain, or something we call metatarsalgia, which is just, kind of the medical term for ball of the foot pain. We see an increase in hammer toes and bunions, because when you're in a high heel shoe, you are putting all of your weight to the ball of your foot. So now imagine with every step you're taking, that pressure is not being evenly distributed across your foot. It's all being put to the ball of your foot. So we get a lot of pain that way. Right. We've also seen people with stress fractures wearing high heels all the time because of all the pressure they're putting on their foot.
A lot of repetitive stress in that area, and eventually it just breaks down a little bit. So, so back to the plantar fasciitis. So it sounds maybe a little scary to some people who never heard it. Is that typically a surgical issue, or is it a non-surgical treatment for that typically?
Right. The great thing is that most people respond to some type of conservative treatment regimen, which is really nice. I mean, most people never get to surgical treatment for plantar fasciitis, and it's one of these things where we always say, again, don't ignore foot pain. It's one of these things that if you come in sooner than later, it's very easily treatable, and doesn't become a chronic condition, because unfortunately it is something when people wait that it can become a chronic condition. And I do have patients that sometimes come to see me for the first time and they'll tell me they've had it for 3 or 4 years, but if you just start to notice pain within the first month, the first couple of months, it's very easily treatable. Typical treatment regimens are stretching exercises, icing exercises. Typically what happens with the plantar fasciitis is just the plantar fascia is just this large band on the bottom of your foot that supports your arch. So typically it tightens up, it gets overworked, and then it becomes inflamed. So if we stretch the plantar fascia, we loosen it up, we decrease the inflammation, very often that can be enough to get rid of the pain.
And then going forward, you might recommend a heel arch, an orthotic, or something that might prevent that same person from reoccurring that problem?
Absolutely,
or having that problem?
Yes. So orthotics play a key part in treating plantar fasciitis, not only to treat the condition itself, but then long-term control or maintenance so it doesn't come back. Because as I said before, very often the structure of someone's foot predisposes them to the heel pain or the plantar fasciitis. So if you happen to be on the low arch side, a custom foot orthotic with an arch support built into it can very much support the plantar fascia, support your whole foot and body, keeping your, what we would like to say, your lower extremity, so everything from the lower back down to the toes in alignment, which then can take care of the pain long term.
I think what's important for some of the families with younger athletes out there, the 8, 9, 10 to 14-year-old children, is sometimes overworking them and their stress on their body, and as the kids are growing, there are some growth bone diseases that can happen, like a Seaver's disease or things of that nature, where heel pain can mean other things. It can mean a little too much activity.
Absolutely,
and
absolutely.
Orthotics can help assist in that role as well.
And that also goes to the point that a lot of people, with the age of the internet, everyone is online looking up their symptoms and getting diagnosis, and not always are they giving themselves the proper diagnosis. So again, you should come in, see a podiatrist, because there are other things that can mimic plantar fasciitis. And you mentioned one, Sever's disease, which is very common in children. And again, it sounds like a very scary word, but it's also inflammation of the growth plate of the heel bone in a child, and is usually due to overuse. And these days we're seeing it more and more, because most kids that play sports, it used to be you played one sport. Maybe you played, basketball in the winter and then you took the spring off. Now we see kids going from fall sports directly into winter sports, directly into spring sports, and everything is overlapping. Exactly, everything is overlapping. They never have a chance to rest. And then they're going from different, terrain. They're going from an indoor hard court, let's say, to, a grass field, and that changes your balance and it puts stress on different tendons and ligaments. So very often I do see young kids where we're making them a foot orthotic or an arch support that we put in their shoes just to keep them in a good support, stable and in alignment.
And I'm first patient. I had that as a kid, so it worked for me. It was very helpful, the orthotics, and I think I've worn orthotics since I'm 10 or 11 years old. And it's been very helpful in terms of that particular condition, and then going forward, it probably has prevented me from having other problems.
Absolutely, orthotics, are really a wonderful thing for a lot of people, and what's also important is, even though I'm a podiatrist and we treat the foot, I always say to my patients, like the old children's song, your hip bone's connected to the knee bone. Everything from the lower back down down to the toes is connected. So I'll have patients come in, young athletes, that tell me they're having knee pain, but it's really because they have a low arch, and when they're walking, their foot is throwing their knee out of alignment, and just by putting an orthotic in their shoe, then we can put everything back in alignment and their knee pain goes away. And you wouldn't necessarily think, well, why am I going to the podiatrist for knee pain? But it's really because everything is connected.
Yeah. And even technology in orthotics has maybe changed a little bit over the years. I know back in the day they used to just cast you with plaster.
Right, yes.
Sometimes now they'll scan you. Sometimes they'll use foam imprints. Weight bearing, semi-weight bearing, non-weight bearing.
The technology has definitely improved.
Is there any particular methodology that you prefer?
I typically like the foam casting. Okay. I think it's a nice kind of medium between the old plaster casting and the new kind of scans. I prefer to do it, on a weight bearing, because truly when you're weight bearing, which means, standing down or putting your weight on your feet, it kind of gives you a true impression of how you are when you're standing or when you're walking. So that's what I like about it. A lot of the scanning machines, although they're always getting better, are typically with patients, sitting. And not that they're great, but you don't always get a full kind of picture of how the patient's foot is when they're weight bearing.
When you put a lot of weight on any joint structure, your toes can splay out, your tendons can kind of collapse a little bit.
Exactly, yes.
So you want to correct some of those issues and see what's going on.
Correct, yes.
All right. Now, obviously, you probably see other systemic problems that people don't think about. Diabetes. People may come in with certain things that they don't even know may be diabetic related,
right, yes.
But a lot of people that don't know, you can get ulcers on your foot, with long-standing
I always
diabetes.
like to say that your feet mirror your general health. So very often you can get signs of other medical conditions in your feet, and sometimes we identify it or you see the signs in your feet first before you see it anywhere else. Diabetes is a big one. So very often, patients will come in and they'll have maybe a decreased circulation, so they don't have as much blood flow to their feet, or they're starting to get skin changes, or discoloration, thickening of the skin, or they're starting to get changes in their nails, fungal toenails, which is very common. That very often can be a sign of diabetes. It can be a sign of poor circulation. So sometimes we can see things in the feet that are mirroring what's going on in the rest of the body. So it's very important, to have what we call like an annual foot exam. So even for patients that don't have any foot pain, that aren't having any problems, we always say like your annual physical exam, you should see a podiatrist at least once a year, because we always like to be preventative. We always want to try to catch things early and be able to treat it, especially with diabetics. I mean, the last thing that any podiatrist ever wants to do is to tell a patient, you're going to lose your limb, and very often that can be prevented. In fact, they say, studies have shown that an annual or foot exam or a routine foot regimen can lower amputation risks by 45 to even 80%, which is amazing. Yes, which is significant.
And if you catch certain small ulcers and you can treat them
easily,
early on, and
treatable, exactly.
And what are some of the treatments for like diabetic ulcerations of the foot?
A lot of it is what we call offloading. So a lot of it is due to pressure. So patients are putting too much pressure on their feet, and it also has to do with what we call neuropathy. So a lot of patients with diabetes and other medical conditions will get like a loss of sensation or a decrease in sensation. So you and I may step, let's say, on a pebble or even get a pebble in our shoe and it feels uncomfortable. So we automatically take our shoe off and we remove, the foreign object. But a diabetic with a little loss of sensation might not realize that there's a pebble in their shoe. So they're walking on it for hours, even days, and the skin breaks down. And then when the skin breaks down, because it's usually on the bottom of the foot, which is, a weight-bearing surface, the ulcer gets larger and it's much harder to heal. So first treatment is usually what we call offloading, which can be done in a number of ways. It can be done with what we call a walking cast boot, which probably a lot of people have seen. They almost look like, I describe them as ski boots.
Yeah,
and we use them, for a lot of different, conditions. Yeah. But that can be enough to offload it. There's something called contact casting, total contact casting, where patients are put in a cast that allows them to walk in it, but takes the pressure off of the area. So taking pressure off of the area where you have the ulcer is key. There are now always advancements in type of wound grafts and skin grafts and, kind of wound gels to help, create
Aren't there like wound care centers or
exactly, yes, and they do hyperbaric, hyperbarics, which has been shown to really help. I mean, it's not for everybody, certain medical conditions, certain people, can't tolerate hyperbarics, but it does help to bring oxygen to the surface of a wound and to help with healing. And wound care is a huge part of podiatry, and it's really become a huge part of medicine in general. Most of the major hospitals have wound care centers, and again, it's kind of a multidisciplinary approach. So in the wound care center, you will have a podiatrist, you'll have a vascular doctor, you'll have a general surgeon, you'll have a wound care specialist, and everyone kind of working together to get a wound to heal, which is kind of a nice approach, yes.
So prevention is key, and then if you think you have a problem, obviously stay aware and be on top of what's going on and work with your podiatrist to make sure nothing gets out of control.
Exactly. Everyone should inspect their feet on a regular basis, which most people don't even look at their feet.
You did mention one thing that's a little, some people may say, well, hey, if I have toenail fungus, do I automatically think I have diabetes? Probably not.
Right,
It may be an indication.
Yes.
But sometimes, toenail fungus is kind of a pain, right? It's not that easy to get rid of.
No, it's very hard. Yes.
Medications over the years have changed.
Yes.
There's been some laser technologies. What's the best approach for people that are looking to get rid of toenail fungus?
With toenail fungus, and it is one of the hardest things that we treat. We could do surgery all day long, and it's easier than trying to treat
put
toenail.
This stuff on it, take this pill.
Exactly.
Cut your toe off.
And although people do ask sometimes about. But first and foremost, always, and I always go back to this, is just don't ignore. Just don't say, well, this is normal. My toes are changing color. My toes are getting thick. This is normal aging process. So first and foremost, if you see changes, go to the podiatrist. Because also there are other conditions that can mimic a fungal infection of the nail. So you don't want to be just getting a treatment over the counter, treating it, and then you're not treating the right condition. And other conditions can be trauma to the nail. So we see it a lot in athletes where their nails start to change. Other skin conditions, psoriasis and eczema, can show changes in the nails. But if it turns out that you do have a toenail fungus, you want to treat it as early as possible. And it really is also kind of a multi-system approach.
Laser work, the pinpoint lasers?
I do it in my office. When it first came out, everyone said, oh, this is wonderful. This is going to be the cure for fungal toenails. And it's not that, okay? And so I usually never use it as a first line of treatment. I always use it in conjunction with something else, whether that's a topical medication or whether it's the oral medication. Because part of the problem with treating toenail fungus is all the treatments work with the growth of the nails, and even though we trim our nails on a regular basis, the average nail growth cycle is about a year. So it takes a long time. So reinfection is a big problem. So if you do a laser treatment and let's say it works and you're getting good improvement, as the nail is growing out to get the cosmetic improvement of the nail, you can end up getting reinfected. So I usually, if we're going to do a laser treatment, use topical medication for maintenance while the nail is growing out, or if you're going to use the oral medication, which is very, very effective, but not an option for everybody. It does have potential for certain side effects, but if you're going to use that, again, do a laser treatment with it or use the topical medication with it. And also important to disinfect your shoes when you're treating fungal infections of the nails. So most people think you just have to treat the nail, but yes, fungus loves to grow in moist, dark places. Our feet are constantly sweating, whether you think your feet do or not, and they are.
It is what it is, but there are treatments. And
there are treatments, yes, and it can be. It's just a matter of coming in and figuring out what is the best treatment regimen for you.
Now, for podiatry, obviously, there's sort of surface conditions, and there's probably more like bone and tendon conditions that require surgery. So I don't know if a lot of people even recognize that podiatrists are surgeons of the ankle and foot, and they can do different types. So what are some of the more common procedures that you do and the
well, what's so great about podiatry, though, is that we are so highly specialized in just the foot and ankle. So if you go to a podiatric surgeon, that's what they're doing all the time. They're doing foot surgery, which is nice. So you know that they have the experience and they're up on the latest, technology and the latest, procedures. For me in my practice, I treat a lot of what we call forefoot. So that would be treating bunions and hammer toes. That's a lot of the surgery that I do.
Right. And bunions are the one with the big toe.
Yes, when you have a large bump on the side of the big toe.
Right.
And a lot of that is hereditary, which a lot of people don't realize. You know, shoe gear plays a factor, and we do see it a lot in women because we're wearing our high heels and we're walking to work in high heels and the tight, narrow shoebox. Exactly. Right. But a lot of it is a genetic component to it. So you are predisposed to getting them. You know, if your parents had it or grandparents had a bunion, you are more likely to get a bunion. And there's definitely a surgical correction for that.
Now, is it cosmetic, or has it become to the point where it's so painful that people can't?
Yes, absolutely. It's because of pain. You know, I always tell my patients we don't do bunion surgery for cosmetic appearances. You know, if it's purely how it looks, just get a wider pair of shoes. But a lot of people, it can be very painful. A lot of people have very difficult times walking. It's affecting the activities they want to do. And we always try to start out with conservative treatment first. We always try to do a period of conservative treatment. And if patients are responding, wonderful. If not, then we get to surgery. So I will have patients where we talk about proper shoe gear. We talk about cushioning the bunion. We talk about exercises for the toe to help prevent the bunion to progress. And if at that point, you know, they've been in the wider shoes, they've been in the sneakers, they've done all the conservative treatment, and they're still having pain, that's when it's time to consider surgery.
Okay, and then you mentioned hammer toes, I think it was?
Hammer toes. So we have lovely names for everything. Hammer toes is basically a general term for any type of bend in the toes. So when the toes start to bend and they're not straight anymore, that is considered a hammer toe. And interestingly enough, you can get pain in the toe itself from the hammer toe, but a lot of times people will come in with pain to the ball of their foot. Because of the bend in the toe, you end up putting more pressure to the ball of the foot. They'll start to get calluses, which is very thick skin, which can become very painful. They can also get the opposite, breakdown of skin and ulcerations, and they can get corns, which is also some thickened skin due to pressure or friction on the tops of the toes. So they can be very painful. Also, again, we always try to start with some type of conservative treatment, but very often we do have to go to surgery to straighten out the toes.
And the recovery on those are usually pretty, you know, reasonable. Obviously, you have to stay off your foot for a while, but it could be a 6 to 8 week recovery or longer.
It is. You know, the thing with foot surgery, is the weight-bearing issue. You know, so the surgeries themselves are usually not too long. Always an ambulatory surgery where you go home, you know, the same day. But you're off your feet. You have to take it easy. You know, and so even
Saturday night I had dinner with 2 boots.
Okay.
One husband, one wife, 2 different families, 2 boots.
Yes. So you know, we do like to protect, you know, the foot after surgery. So I've had some patients that have told me after, you know, foot surgery that they had a hip replacement and it was an easier recovery, not because of pain, but just because they were able to get back to their normal activities faster because, again, the foot is a weight-bearing surface, so we try to protect it a little bit longer. And it's also with newer techniques in bunion surgery and hammer toe surgery. There was a time you'd go to the hospital for bunion surgery and you'd stay in the hospital for a week and they'd put you in a cast and you'd be on crutches for, you know, 3 months. Now you literally walk out of the hospital in a special shoe, so you're weight-bearing right away, which is wonderful. You don't have to be in the hospital and you can walk, but it does mean it takes a little bit longer to heal from it.
So are there any special like technologies or any new advancements that are coming out in like the foot and ankle realm, like ankle replacements, things of that nature? I know there's maybe a little more advanced types of procedures, but for people that suffer with like significant, you know, arthritis or have had significant traumas to their foot and ankle over the years,
absolutely. A big kind of new technique that they're always trying to perfect now is what they call PRP, or plasma-rich protein, protein-rich plasma, and basically what that means is they draw some blood from the patient and they spin it down in a centrifuge machine and they get the plasma-rich protein out of the blood and they inject it back into patients. So typically it's for conditions like a tendonitis, a chronic inflammation of your Achilles tendon, a chronic plantar fasciitis. That's become a big technique or procedure now in podiatry and even orthopedics, because it's shown that it has increased healing. And a lot of patients have gotten kind of that end stage of conservative treatment with chronic tendinitis or fasciitis that we're now talking about going to a surgery. We've seen that by injecting this plasma-rich protein, that it's actually ended up healing the tendons or the ligaments, and they've been able to
Achilles
avoid.
tendinitis and or plantar fasciitis.
It can be used for any type of.
I think the research on the Achilles has been pretty good.
It's been very, very good.
I think that tendon in particular, I don't know why, but it seems like it's like versus like other areas of the body, like tennis elbow or.
True, yeah. You know. But they've seen good results with the Achilles tendinitis, and now since they saw good results with that, they're doing more kind of studies with plantar fasciitis and seeing that a lot of people, before we have to get to surgery, when you have this chronic inflammation or even kind of small tears in the plantar fascia, that is a way of kind of healing it and, you know, allowing people to avoid surgery, which is nice.
That's great. And then in terms of like, I don't think stem cells are that prevalent in what you're doing.
Not
I mean,
yet,
you can have osteoarthritis of different joints sometimes. You know, the big toe joint, the ankle mortise joint.
And that's what they're trying to improve more on. You know, we hear about hip replacements, knee replacements. Kind of first toe joint replacements has been something that's been going around for a while, the past 10, 15 years. Hasn't quite been perfected yet, and typically something that we use for severe arthritis in the toe joint. And I wouldn't say not perfected, very good technique for some people, but something where they just haven't, where it doesn't last as long. You know, as a hip replacement, they might say you have, you know, 15 years with your new hip or even longer. Sometimes with a first toe joint replacement, you know, it's 5 years before you're going back to another surgery.
And for all our football fans out there, you know, turf toe.
Yes.
But just tell them what turf toe really is. They just hear the term turf toe.
You know, as simple as it is, it's really just jamming of the first toe joint. So a lot of, you know, we see the football players,
for a long time.
and they're all lined up, and all of a sudden, you know, their body goes forward and their foot stays stationary, and they just jam the first toe joint. But it could be very painful, and it could even cause a rupture of the ligaments and the tendons that hold the joint. It could even go to as far as a break in the bone. So it can be very painful and really does require a true period of resting and splinting to be able to go back and not have long-term complications. So as simple as it sounds and as funny as it sounds, it can actually become a chronic condition.
But the rest and the prevention really just helps it heal.
Absolutely makes a difference.
I mean, if there are any torn tendons, and you know, people have a lot of sprained ankles, and then you know, I think it's important to understand that when you even do something like that, you know, turf toe or sprained ankle, you always want to have it evaluated, because you never know if there's an underlying tear or an underlying fracture. Like things, surely if things aren't getting better progressively quicker, there could be more damage.
Correctly.
In rare cases, you get like different AVN of the talus bone or something.
I always say, you know, if you've had pain or injured your foot, you give it about 3 to 4 days, you know, and the classic kind of RICE, you know, rest, ice, you know, compression, elevation, you know, and if in 3 or 4 days you are not better, then you better be at the podiatrist's office. You know, and obviously sooner, but some people say, well, I sprained my ankle, it doesn't feel so bad, so let me see. But within 3 or 4 days, if you're not better, you want to come in, because it could be a sign of like an ankle sprain that's more severe, and now you've torn a ligament, or you have created a chip fracture in your ankle, you know, a small piece of bone has come off. And I've seen that all the time, where patients will come in 3-4 months after an ankle sprain and their ankle's still swollen, they're still in pain, they're not able to exercise, and then we end up finding out that they've torn their ligaments and now they need surgery, or exactly, or there was a break and they've been walking on this break for 3-4 months. So again, you shouldn't ignore an injury, you shouldn't ignore pain, and you should always have it evaluated, because something that would seem simple like an ankle sprain can be much more, you know, complicated than it appears.
Right, and we've always had those fun nights when we wake up and we jam the side of our foot.
Yes.
And, you know, they call that the bedroom fracture.
Exactly, yes.
Well, and it's dark, we can't see where we're going. We jam the side of our foot into something.
Especially that little toe, that pinky toe gets into a lot of trouble. And that's another thing that people ignore. You know, I so many times have patients come in and they'll come in for, let's say, toenail fungus, and I'll say, you know, your little toe is swollen, and they go, oh I hit it 3 months ago. Well, why didn't you come in? Oh, there's nothing you can do. What if it's broken? There's nothing you can do. First of all, not true. Not true.
Well, those are things, you know, like these shows we try and educate people and tell them about podiatric medicine and why it's important to work with different specialists. And, you know, as a podiatrist, I'm sure you work, like you said, you have a team of different doctors based on different conditions. I'm sure for different conditions, you know, you do work with like rehabilitation and physical therapists and we spoke a little about some other alternative acupuncture. And sometimes people can have numbness and tingling in their foot, and they don't even realize that it's a back problem,
Absolutely.
right? And then sometimes that coordination with another healthcare provider that will, hey, it looks like it's maybe an S1 nerve root, radicular pain, but it's just sometimes it only shows up in the foot, and they have no back pain.
Exactly.
It's kind of weird, but it happens.
It's true. I see it all the time.
I got a little numbness right here, but I don't know why. So
I very often have patients will come in and their complaint is their big toe is numb, and we say, well, we have to see, is it coming from the foot or is it from somewhere else? And very often we'll find that it's a condition with the back, and then we are talking with physical therapists and chiropractors, and we're talking with the orthopedics, and it's really kind of multidisciplinary approach, and that's what I really love about podiatry. Everyone always asks me, why did you pick the foot? But that's what I love about podiatry. It's such a specific area, but we have to look at so many different things. Where vascular doctors looking at circulation, where rheumatologists looking at arthritis in the foot, where orthopedics looking at foot structure, where infectious disease doctors treating infection. And then when it comes to treatment, it's not just us. Very often we'll treat a condition and then we refer you have to see your rheumatologist also, because there's arthritis is playing a part in this. You have to go to physical therapy because you need to strengthen your muscles, in your feet and in your legs, So that's what's kind of nice about it, that, you can bring in all different fields.
Well, it's a nice field, and it's a great profession. I think anyone that is really doing anything, we all have feet and they all have problems.
Yes.
They should all have a good podiatrist that they work with, and it's part of their sort of like their health team, so to speak.
Absolutely,
and I think it's important. And so it was very informative. Thank you for coming on the show. We appreciate it. So if anyone needs to see you're at Scarsdale Medical Group, and you're down in Heathcote and in Harrison as well.
Yes,
okay,
yes.
All right. Well, thank you for being here.
Thank you so much for having me.
I'm Dr. Siegel. Thanks for watching Health IQ, and we'll see you at our next show. Thank you. Bye-bye.